Okay, so we made it through 1 week of our online learning. I hope the things I'm doing aren't too complicated for you guys. If anybody has any questions or anything related to all this, please make sure you're emailing me. And let's go ahead and move forward with this. We're going to start with the knee. Try to do the same thing we did with the last chapter. Hopefully this works. Okay, so the knee is considered one of the most complex joints in the human body. It's most frequently injured because many sports place an extreme stress on it. Commonly considered a hinge joint, its two principal movements are flexion and extension, but there is also some rotation at the tibia that occurs in some cases, so it is a little bit of a modified hinge joint. Stability really depends on the ligaments, the joint capsule, and the muscles, so there's a lot to keep the stability of the knee. And provides stability and weight bearing and mobility and locomotion. And locomotion is just movement. Alright, knee anatomy. So the knee joint has 4 bones: the femur, the tibia, the fibula, and the patella. These bones have several articulations between the femur and the tibia, between the femur and the patella, between the femur and the fibula, and the tibia and the fibula. The surface of the knee joint are completely enveloped by the largest joint capsule in the body. So a joint capsule is basically a thin, soft tissue structure or membrane that kind of encapsulates the joint. It's a synovial membrane, and it lines the joint capsule. And there's also fluid within that capsule to help keep the joint lubricated and moving properly. Just think about any kind of lubricant in any kind of structure that allows it to move properly. The distal end of the femur extends to the lateral and medial into the lateral and medial femoral condyles, which are designed to articulate with the tibia and the patella. In similar ways that you remember with the ankle joint, your tibia comes down and your fibula comes down and on either side to articulate with the talus. The patella, or also known as the kneecap, moves up and down in the groove between the 2 femoral condyles, and the quadricep muscle groups contracts and relax. And the proximal end of the tibia or the tibial plateau is very flat, and it must articulate with the round condyles of the femur. So let's just take a look at all the things I just said on the picture here. So we've got your femur, here's your tibia, and then your fibula. You can see this is relatively nice and flat in the front, and it's got a little bit of contours in the back to kind of contour with that space in the femur. Here's your patella, and your femur has that sort of U-shaped shape to the front, and that's where the patella articulates as it moves into flexion and extension. Here's your medial epicondyle, lateral epicondyle, which you can feel on the inside of your own knee that stick out. Later when we talk about the ligaments, that's where here our medial collateral ligament attaches and then our lateral collateral ligament attaches. Okay, your medial meniscus and lateral meniscus are fibrocartilage discs that help to allow the joint to move properly. It sits on the top of the tibia in that flat portion. If we go back and look, it sits right in here. This will be the lateral and the medial. They make the rounded femoral condyles fit better on the flat tibial plateau. They help cushion any stresses placed on the knee joint. Their blood supply is greater in the peripheral lateral portions than in the medial portions. So better blood supply here versus over here. We can take a look at that. These red lines kind of show you where the blood supply is. So You can see this is the lateral meniscus here, and you can see there's blood supply going through it. This is a medial, and you can see that blood doesn't get to all of it, mainly just this area. So this is why with medial tears, a lot of times we're not as successful with having those heal, so a lot of times these need surgery. Okay, ligaments. They're the major stabilizing ligaments of the knee are your cruciate and collateral ligaments. We have two cruciate ligaments, your anterior cruciate, which we know a lot of people know more about that, more so than the posterior cruciate. The ACL prevents the tibia from moving forward relative to the femur during weight bearing. So it's basically keeping the femur from sliding backward when the knee is extended. And it stabilizes the tibia against excessive internal rotation and serves as a secondary stabilizer when there's an injury to the collateral ligament. So basically, it's keeping that tibia from moving forward. So anytime in hyperextension that tibia is pushed backwards, that's when we worry about an ACL tear. Posterior cruciate is not as easily torn, okay? When you hear the word cruciate, that kind of means cross. So these ligaments cross each other in the joint, and I'll show you a picture of that later, where they particularly are. But anterior, we always talk about that as being in the front, posterior in the back. So the tibia, the PCL prevents the tibia from sliding backward now relative to the femur, the opposite of the ACL. So the femur from sliding also prevents the femur from sliding forward when the knee is extended. And a lot of times when we talk about this ligament, it's very difficult to tear it. You have to have a really kind of perfect storm injury where you have the tibia sort of pushed backward on the femur. It's usually called like a dashboard injury. It's very common in car accidents where the dashboard pushes against the tibia and pushes it back and causes a PCL tear. Okay, now your collateral ligaments, you have a medial and a lateral collateral. Okay, they stabilize the knee from side to side, or valgus and varus forces. So a valgus force is going inward or medially, and a varus force is going outward or laterally. So it protects the knee from valgus stresses on the lateral surface of the joint, and has two parts, including a superficial and a deep portion of it. And then the lateral collateral is attached to the lateral condyle of the femur and the head of the fibula, and resists varus, or a force going from the medial side outward. So here's a picture that shows you our ligaments. You can see this is a view from the front, it says anterior. So this structure is the ACL, behind it is the PCL. You can see your lateral collateral, You can see your lateral collateral here, and your medial collateral here, and then you can see your patella tendon. The patella is taken off, so you can see in there. Muscles of the knee joint. There's a number of muscles that work together in a highly complex fashion to keep the knee functioning properly. Contraction of the quadricep group on the front of the thigh causes knee extension, and contraction of the hamstring group on the back of the thigh, along with gracilis, sartorius, popliteus, gastrocnemius, and plantaris muscle cause flexion. Okay, so there's a lot of muscles within the upper thigh and knee joint area. And here just gives you another look from the side, where it'll show you where your quadricep tendon comes down, attaches down here. This is your tibial tuberosity on the tibia, and this is our patella tendon. Okay, that's part of our musculature. And now let's take a little closer look. So here's our hamstring group on the back. We've got your bicep femoris, which is right here, which is more on the outside of the leg. And then two smaller muscles, your semitendinosus and semimembranosus on the inside of the leg. Then you've got your quad. So these are a flexion group, all right? Here's your extension group. You've got your rectus femoris, which is the bigger muscle in the middle, and the vastus lateralis, which is on the outside, so lateral. Vastus medialis is on the inside, and it says, and there's one portion of the vastus medialis that is called the vastus medialis oblique, where the fibers you can see run at more of an oblique angle versus up and down. So 3 muscles in the back, 3 muscles in the front are our main muscle groups. You can also see we have your gracilis, which is another muscle that helps with flexion, your sartorius, which also helps with flexion, and that kind of covers most of the muscles of your upper thigh and knee area. We're going to also talk about the iliotibial band. Okay, this originates up on the hip, and as another muscle and comes down into a tendon or band that we're going to talk about that gets injured sometimes. Here's your gastrocnemius, which is your calf, and another muscle that helps assist in the function of the gastrocnemius is the soleus, which isn't shown here. So there's a lot of muscles with the anatomy of the knee. Main ones I want you to be concerned about are your quads and hamstrings when we're talking about anatomy and the muscles in particular. So preventing injuries, I'm not going to get too much into this. We've talked about this a lot before with other body parts. So physical conditioning and rehabilitation, total body conditioning is required to avoid knee injuries. We've talked before about the body being a kinetic chain. Things, lower body affect upper body. Muscles around the knee joint and the hip joint must be strong as possible, and strengthening exercises are essential in preventing re-injury. Shoe type, again, having the right kind of shoes is going to be helpful for all of our bodies, all of the joints of our body. I'm not going to get into that too much. Knee braces, functional and prophylactic knee braces, so something that's going to allow you to function but also be protected but also be functioning. Okay, used to prevent and reduce the severity of injuries, worn to provide some degree of support to an unstable knee. They can be customized or molded. Their effectiveness is controversial, but a lot of times it can be helpful psychologically, and if it's worth, it usually is worth that. But it definitely combined with rehab is the best case scenario. All right, moving into assessment of the knee joint. Always want to start with a history. We're going to ask questions that we want to ask. Questions asked to determine the current injury may include the following. So, what were you doing when the knee was hurt? So that's going to help us figure out the mechanism. What position was your body in? Did the knee collapse? Did you hear or feel anything unusual? A lot of times with tearing of a ligament, you're going to hear a pop, like we heard a pop with the Achilles tendon rupture. Could you move your knee immediately after the injury, or was it locked? That might key you in onto a meniscus injury. Did swelling occur? Right, swelling is usually associated with some sort of tearing of some sort, or not complete tear, but at least some tearing. Where was the pain? So that helps us figure out what structures might be injured. Have you hurt your knee before? I always like to ask those questions because obviously we want to know if there's a history, but we also want to know how sort of they handle injuries psychologically. Questions asked to determine recurrent or chronic injuries. Okay, what is your major complaint? When did you first notice the condition? Is this a recurrent swelling? Does the knee lock or catch? More focused in on the meniscus again. Is there severe pain? Do you feel any grinding or grating sensations? We'll key in on those questions a little later with some of the injuries. Does your knee ever feel like it is going to give way, or has it actually done so? And that leads us to the instability part of a knee injury. What does it feel like when ascending or descending stairs? What past treatment have you undergone? And is there any training or footwear changes? Okay, observation. So now we're looking at the patient. doing a visual examination of the major components. The athlete should be observed in a number of positions: walking, half squatting, and going up and down stairs. The leg should also be observed for symmetry. So you'll look and make sure that, with both their quads, they look like one side is maybe not as strong as the other. Same with the hamstrings, looking for swelling in the knee joint, things like that. Establish whether both of the athlete's knees look the same. Do the knees appear symmetrical? Is one knee obviously swollen? Is the muscle atrophy apparent? And you can really look at, even if their knees look the same, look at their patellas and see, they look like they're rotated in or out, or something, or things like that. It'll help you kind of lead yourself towards the injury also. Observe the athlete as he or she walks. Does the athlete walk with a limp? Can the athlete fully bear weight on the affected leg? Is the athlete able to perform a half squat to extension? And can the athlete go up and down stairs with ease? Okay, palpation. Again, anytime we're doing this, we want to make sure we work away from the injury and toward the injury. They should be supine or sitting on the table with their knees flexed to 90 degrees. Bony structures of the knee should be checked for bony deformity or pain. Lateral collateral and medial collateral can be palpated for areas of tenderness, and the joint line should be palpated around the knee joint, and tenderness at the joint line may indicate injury. Okay, special tests. There's several special tests we're going to talk about. We're always comparing the injured knee with the uninjured, obviously. We always look at the uninjured first, and then we look at the other knee to determine any differences. We want to look for an endpoint field to use the determination to the degree of instability. An endpoint is kind of a hard thing to understand, but when you see the pictures of these tests, when we move forward, you're going to see we're trying to move the knee joint in one direction or the other. Do we feel like there's something stopping me at some point in the motion, or is there nothing stopping me at all? Or maybe it is stopping me, but it's going further on the injured side versus the uninjured side. So how we classify these: a grade 1 sprain, the endpoint is still firm with little or no instability. So you pull that and everything seems nice and tight. There may be a little instability, but for the most part it seems good. And the pain, there's usually some pain with that, obviously, because there is an injury there. In a grade 2, the endpoint becomes a little more soft, more pronounced instability, and now we have more of a moderate pain. In a grade 3, in a complete rupture, it's extremely soft to the point of you may not even feel it at all, and it's usually severe pain and definitely a marked instability of the joint. All right, so our first special test is called the valgus-varus stress test. Valgus is the top picture, varus is our bottom picture. So in the valgus test, we are having the knee about to 30 degrees of flexion, so it's not completely straight. We're stabilizing one hand on the ankle, the other hand on the outside of the knee, and pushing in, so we're stressing that medial ligament. And then we just switch our hands up, moving our hand into the inside and stressing the lateral ligament right here. Okay, so again, going back to our previous slide, we're looking for, is there a firm endpoint? Is it soft? Is it very soft to the point where it's not there at all? Lockman's test. Okay, this is a difficult test to do if you have small hands. So I'll show you another one that would be good if you have smaller hands and you can't do this. But you want to be able to get your hand, you can see you want to get it around the upper calf and around the lower thigh. So if this is a big person, it's going to be difficult to do that, but you're just basically alternating the motion of your hands. One's pushing up, one's pushing down. We're looking for excessive motion, and if we see that, it's usually indicative of an ACL injury. Again, looking for grade 1, 2, or 3. A lot of times, unless you get to these very quickly, it may be that you don't feel that motion, but there could be still a tear in there because the muscle will pretty quickly help to control the joint and not allow you to move this knee and feel that tear. Okay, your anterior posterior drawer, this is better if your hands are a little smaller and you can test the ACL, but then also the PCL. So here we're testing the ACL, stabilizing with our butt sitting on the foot. We're having the person to about 90 degrees, and we're pulling out this way. We're looking for that excess motion. Remember, the ACL is supposed to prevent the tibia from moving anteriorly, so we shouldn't be able to move that. If we can, then we're concerned that there's a tear there. Conversely, we're going to do the same position, and we're going to push backward or posteriorly. Again, remembering the PCL is supposed to limit posterior motion of the tibia on the femur. If that happens, then we're worried about a PCL tear, or at least an injury. Apley's compression test. This is helping to detect a meniscal tear. So we're pushing down and twisting. So you can imagine as that meniscus sits on the tibial plateau, we're driving that down into the femur and twisting it. If there's an injury there, that's going to hurt. Okay, functional test. Knee function is tested by making the athlete perform the following movements in progression. A lot of times we're going to be doing this as we progress our athlete back to the field. Always want to start with walking, forward, backward in a straight line and a curve. Jogging, straight, curve, uphill and downhill. Running, forward and backward. And then sprinting, straight, curve, large figure eight, small figure eight, zigzag, and karaoke. Okay, getting into our injuries. The medial collateral ligament is our first injury we're going to talk about. These injuries occur as a result of a medially directed valgus